Okay, super. Ready to go. As I mentioned, I'm going to talk about bipolar disorders today. Sarah and I came up with the entire list of didactic topics for 2020 about 5 months ago. And we were in a pattern of sort of brainstorming and figured we would branch out and cover more areas. It was probably a little bit grandiose of me to choose just bipolar disorders as the topic for about a 15-minute presentation, because it's a very big topic. And so in an effort to try to narrow down the focus, I put it out to social media. What sorts of things about bipolar disorder are most on people's minds? And I got actually many interesting responses. They were a lot along the lines of concerns about overdiagnosis, and we've certainly had questions come up in this group before along the lines of, why is it that so many people are taking lamotrigine these days, and so forth. So I'm going to touch upon the prevalence estimates of bipolar disorder. And there were also questions around medications, which medications are best, and so forth. So I'm going to try to touch upon medication use. And so with that as a sort of a backdrop, I'm going to focus in on bipolar 2, the bipolar 2 concept, because it seems to me, and also based upon literature review, that is where the biggest growth in the estimates of bipolar disorder will occur. And that also seems to be the topic about which there is most confusion amongst clinicians and also consumers about how to treat it. So I'm going to talk about prevalence, and I'm going to focus then on bipolar 2 concept, and then within bipolar 2 focus specifically on the depressive episodes and their management. So first to the question, are we seeing increased rates of the diagnosis of bipolar disorder? And the answer is yes, definitely so. The remarkable, as I think clinicians viewing this will know, when you see what is now called type 1 bipolar disorder, classic mania, it is unlike almost anything else. It's very, if you will, easy to name it properly, to recognize what's going on. And for that reason, if you take a very narrow definition of bipolar disorder, the way that we used to do it in, say, 1970 or 1980, the estimates of its prevalence in the population are remarkably constant. So roughly between 0.5 to 1.5%, with more estimates being on the fraction of a percent. So let's just call it, for argument's sake, 1%. Then this remarkable thing, and on the third row in this table, you'll see that we came around with, by 1987, with formalizing diagnostic criteria for bipolar 2 disorder. And at that moment in time, estimates of bipolar 2 were about 0.5%. More modern estimates are, of course, pegging it higher. And the event that I think is noteworthy in this is 1995. We had an approved, branded, patented, and profitable drug with the indication to treat bipolar disorder. That was Depakote. Prior to that, we had lithium, but lithium is a mineral, and it's difficult to it's impossible to patent it. So you had a couple of manufacturers, but with not a lot of incentive to go and market it. And then in 95, that changed with, some people argue, the things changed. So you had first with Abbott and then with many other companies a incentive to make sure that clinicians are aware about bipolar disorder. And typical of pharmaceutical marketing strategies, regardless of the disease and regardless of the drug, there is the idea that what we thought we learned about bipolar disorder, or insert diagnosis there, back in medical school, is true to an extent, but it's also much more than what we realize. So there's an expansion of the concept of disease. And between trying to expand the diagnostic boundaries around an illness, as well as promoting awareness across the the market, then naturally you see increasing rates of diagnosis. So within a short order, you found increasing estimates of bipolar prevalence. And more recent review points out that with each edition of the DSM, there was more or less a doubling of the bipolar 1 prevalence. And remarkably, bipolar 2, that if we were to reduce the duration criterion for bipolar 2 from the current 4 days to 2 days, we would see a tenfold increase in the frequency of that diagnosis. And if we were to include other forms of hypomania symptoms, then it's been estimated that we would see some bipolar spectrum diagnosis being appropriate in about 10% of the population. And also estimates have shown that there was been a 50% increase in the rate of adults being diagnosed with bipolar disorder. And to me, concerning that the rate of this diagnosis amongst children and adolescents quadrupled following the introduction of following the approval of Depakote, and also with the approval of subsequent drugs with a specific indication for pediatric bipolar disorder. So to the question is, are the estimates of prevalence rising? Absolutely they are. The next question, is that a good thing or a bad thing? And are we doing a good job of recognizing cases that we hadn't recognized before? Or are we overdiagnosing and giving people diagnosis who don't deserve a diagnosis? And that question can only be answered, the question hinges around what's the real prevalence of bipolar disorder in the population. And that depends entirely upon how you want to define it. So if we officially agree to, for example, reduce the criterion for duration of bipolar 2 hypomania episodes from 4 days to 2 days, then we will see, by definition, an increased rate of growth. And that's where most of the growth has occurred. So we're going to focus on bipolar 2 now. So in talking about whether, just a general note about diagnoses do broadly 3 different things. They help us to take a complex idea and just put it into a 1 or 2 word phrase. So instead of saying there is a condition in which people can spend a lot of time with persistent many days of depression, and then they can have 4 days or more of elevated mood and decreased energy, decreased need for sleep, and increased energy. And instead of saying all that mouthful every single time, we can just say, we'll call that bipolar 2. And once you name something, once you give it that verbal shorthand, then you have the opportunity to put it into categories. So you can take many people that have similar experiences and begin to learn more things about the natural history of this condition. And you might even get to the point at bullet point number 3, where a diagnosis can help you to plan for the future, to answer questions about the future. Will this happen again? What are my chances of this happening again? What are the chances that I pass this on to my kids, and so forth? So diagnosis gives us that ability over time, and diagnosis ideally also gives us the ability to forecast proper treatment. And I will argue later on that that's where the biggest shortcoming of bipolar 2 happens. But let's go on to first at least examine bullet point number 1. How well does bipolar 2 capture some form of reality? And the answer is pretty good. Historically, as I said, what we now call bipolar 1 was originally called manic depression, and it was pretty obvious when people were having episodes of mania, and therefore the diagnosis of bipolar disorder was relatively easy to make. But in the 1960s, the research hospital of the NIH began to track records of all the people that had come in and been discharged who had either episodes of depression or episodes of mania. The primary interest at the time was to see to what extent so-called unipolar depression versus bipolar affective disorder will track to family genetics. Basically how genetically loaded are these conditions. And in looking at those records, they began to recognize a third pattern. So in the table down at the lower right corner, there was a kind of pattern in which people had several episodes of depression and had, several episodes of manias. And we found that in that classic bipolar group, there were increased rates of bipolar disorder in family members. There was a group, unipolar depression, where there were bouts of recurrent depression. There were no histories of mania, and they could find in families that were in this category no added risk of bipolar disorders. And then the third category, what we now call bipolar 2 episodes, they had many episodes of severe depression. They had episodes that were distinctly mania-like, but they weren't at a level of severity which required hospitalization. And so they called that hypomania, and eventually this led to the diagnostic name of bipolar 2 disorder. So to the extent that a diagnosis is supposed to name something that we find in reality or in nature, it's a real thing. There are people that have this third row of patterns of episodes of depression and episodes of attenuated mania. So here's the next big question, though. Is the name really the best one? In other words, if we call it bipolar 2 and define it by these episodes and use the same language of mania and say that the mood elevation, we call it hypomania, this clearly implies the thought that bipolar 2 is part of a spectrum of bipolarity. Bipolar 2 is the same illness as bipolar 1, just in an attenuated form. That might be where we get into trouble. Because the other point of view is that this thing we call bipolar 2 is really misnamed. Maybe this is an entirely different disease that just happens to share mood features in common with bipolar 1. A lot of times when human minds try to make sense of the world, we do it very simplistically and we do it very wrongly. I think that the biggest criticism that one would levy against the spectrum concept is that if bipolar 2 were the same thing as bipolar 1, just a less severe form, then we ought to see that medications that work for bipolar 1 should work equally well, if not better, for bipolar 2. But that's not at all what we see. Here we look at effects on the table. Here we look at effect sizes. This is a meta-analysis from 4 different placebo-controlled trials of quetiapine. And we see here that in the top row, you have effect sizes of around 0.6. In the bottom row, you have effect sizes of 0.4 to 0.5. So rather than seeing that for the less severe illness, the drug is equally or more effective, it's quite the opposite. It looks like bipolar disorder type 2 is less likely to respond to a evidence-based treatment. So that's something to think about that I don't think a lot of people have yet, but that could explain why we see why I get so many questions about why is bipolar 2 a real diagnosis or doesn't seem to respond so well. Another very interesting finding came from the NIH in 2006. They did temperament or personality inventories of large groups of people with type 1 bipolar, type 2 bipolar, and unipolar depression. And they found that there were actually distinct temperament profile differences. So in classic bipolar disorder, type 1, their temperament seemed to be not a whole lot different from the general population. Contrast with unipolar depression, in which you saw an overrepresentation of brooding, ruminative, sensitive, timidity, and so forth. But then in the so-called, in this bipolar spectrum type 2, they had yet a different pattern of temperaments. So that is just another piece of evidence to suggest that maybe bipolar 2 shouldn't be called, it should be called something different. Maybe it's not simply part of a spectrum illness. So to summarize that, bipolar 2 probably, I mean, there's something that exists that we currently give the name bipolar 2 to, but not really abundantly clear that it truly should be seen as a neurochemical spectrum of bipolar 1. So on to treatment. This is a quote from one of the papers I read. The quality of evidence to guide treatment is poor. Again, probably why we have so many questions around this. And if you find that your patients don't respond the way that the literature might suggest to you that they should, you're not alone. So first of all, should we even bother treating it? Some critics argue that if hypomania doesn't put you into the hospital, if it feels good, if it makes you more productive, and so forth, why even pathologize this? And that's a good point. A counterpoint is that some people during hypomanias will experience anxiety or irritability, and they will then, that will impair their relationships and functional qualities, which is a good point. Even better point is that depressive episodes are more common, and they can be probably the source where more disability happens from this. So we need to think about treatment for type 2 bipolar disorder. Unfortunately, another quote, many standard treatments for mania have simply not been studied. And even when they have been studied, they're not studied very well. So we're really focusing on a diagnosis, and to some extent focusing on expanding a diagnosis without a whole lot of great treatment. When it comes to treating depression in type 2 bipolar disorder, we also have problems. The Canadian Consensus Group on Bipolar Disorder, as well as the International Society for Bipolar Disorder, published guidelines in which the only treatment that got first line credit was quetiapine, but there are problems with quetiapine. So first of all, so far to date, there have been 5 randomized placebo-controlled trials of quetiapine versus placebo in bipolar 2 depression. 3 of those 5 trials found that quetiapine did not separate from placebo. So that's the problem. On the lower left, you see a bar graph in which I have for the authors recalculated their data. It was originally published just as single points with no error bars whatsoever. If you look embedded in the text where you can find standard error of the mean and the sample sizes in each bin, you can calculate standard deviation, which gives you, I think, a better visual representation of the variability about a certain measurement. So bottom left panel, we're looking here at the change of MADRS scores of depression. So going down means getting lower MADRS score, which means less depression. On the 2 left bars, you see quetiapine at 600 milligrams and 300 milligrams. So you get a 13-point reduction in MADRS scores. But check a look at the standard deviation around that mean, and then look at where the mean and the standard deviation group on the far right column is. This statistically is significantly better. So the 0.05 bound criteria, but sorry, I just got a note that my pause because I got a flash that my internet connection was unstable. So I'm going to take out my video to try to get better bandwidth. So although it does reduce depression scores, so does placebo, and there's considerable overlap. And if we look over to the right table at response and remission rates from these meta-analyses, check out between, first of all, the lower dose has higher response and remission than the higher dose. This is pharmacologically weird. it should give one to pause. I'm not saying that this means that quetiapine is ineffective, but it's not typical that higher doses have less response than lower doses. So it's a complex relationship. But if you look here at the response and remission rates for the 300 milligram quetiapine dose versus placebo, they're basically the same. So quetiapine ranks as first-line treatment for bipolar depression, but not really spectacularly better than placebo treatment. I would argue, based upon that, that it should be tied for second-line treatment. I mean, so we can also, there is some evidence use of lithium, venlafaxine, ECT. To my reading of literature, I think that quetiapine is about the same in strength of benefit. So these are your options that exist as first or second line treatment according to modern consensus guidelines. Study that was not included in consensus, I want to talk about psychotherapy for a second. Weirdly and sadly and alarmingly, there's only one group in the entire world that's actually looking at psychotherapies for bipolar depression or bipolar type 2 depression. And this is the best study that they've come up with so far. This was published in 2018, came out of primary authored from Pittsburgh. So they use interpersonal and social rhythm therapy, which is a therapy based on a manual that focuses on relationships and modifying rhythms. So trying to, in addition to working on social relationships, trying to establish regular schedules and sleep patterns and so forth. They compared psychotherapy alone versus psychotherapy, well, technically psychotherapy plus placebo, versus psychotherapy plus quetiapine. Again, quetiapine being the top line evidence for the top line recommendation for bipolar depression. And they found in response rates that psychotherapy alone got 60% in response, which is a 50% reduction of depression severity, 74% for the addition of quetiapine, and both are hovering around 30% remission rates. Although numerically higher in both cases for the quetiapine add-on, these differences don't meet the 0.05 p-value. So these are these differences could be due to random variations in measurement, not necessarily to a true drug effect. But if we want to give the benefit of the doubt to the quetiapine, we can say that it's not a huge add-on benefit, and it does come at the cost of 5% of the sample gained a significant amount of weight in just the first month of treatment. Oh, and speaking of duration, these are outcomes at 8 weeks of treatment. So psychotherapy gives quetiapine a run for its money. Current consensus guidelines argue that we should offer people maintenance treatment and the top line recommended drug being quetiapine, but nobody's really asked the uncomfortable question about what studies show that you have better long-term outcomes from taking quetiapine every day for the next 20 years versus not taking quetiapine or some maintenance drug and simply treating mood episodes as they arise. For bipolar type 1, you can make the case that maintenance treatment or prophylaxis of mood episodes gives you better long-term outcomes. It's not well established, but there is some evidence with which you can say that. And the drug that does that best is lithium. But when it comes to type 2 bipolar disorder, please let me know if anybody sees this, which studies answer that question. I can't find them. So we would risk giving them a multi-year exposure to a drug with metabolic or other side effect risks for I don't know exactly what gain versus simply treating up each episode as they come and potentially treating them with psychotherapy. So to conclude, I think that yes, prevalence rates of bipolar diagnoses are rising. Whether that's a good thing or bad thing depends on how you want to define bipolar disorder, particularly how you want to define type 2 bipolar disorder. Type 2, there's something exists that deserves a name. Whether we should call it type 2 bipolar disorder, suggesting that it exists on a neurochemical spectrum with type 1, I think is debatable. And then we have the question of, if we can name it, that's great. and probably we should try to find out how many people have it. But in looking for all these people, finding cases and giving people a diagnosis, then we have this very problematic situation of having given somebody a diagnosis, but not a diagnosis that comes with a really great body of knowledge to guide best practices in pharmacotherapy or treatment. So unsatisfactory ending, but that's the state of affairs, I think, with at least this slice of the bipolar diagnosis world. Okay, so that was the end of the slide.